Thank you for the invitation. Thank you for being here on this Saturday. If you don't mind, I like walking around a little bit more, kind of be with you all. For the next 90 minutes, just kidding. I'll try to make sure that it's an interactive session with everybody. It's lovely to see some familiar faces. ECMO for lung transplantation is not always our friend. So that's one thing that's through the presentation. We don't deal with recovery when we're talking about the candidates. So some of the things that you'll hear me talk about is going to be very different than what you've heard. And some of the tools that are being used for potential compliance assessments and follow through, they don't have the benefits for us. So it's not to necessarily say what you have heard thus far is erroneous. It's just we have to do things a little bit differently. I do not have any conflicts of interest from a financial standpoint. The pictures that I've showed you for the patients, they have consented to show for you. First and foremost, this is a graph that came out of Stanford University that looked at patients' severity of illness. As you can see, it's broken down to 4 categories. The highest graph there is a scoring system that we give for patients. These are the lowest risk groups. The bottom area, which is the dashed lines, are the most extreme in terms of the scores that they get. This was under the lung allocation score. At the bottom, you can see less than 47 versus 80 to 100. And I drew the line at the 1-year mark. The 1-year mark is kind of the benchmark because people who survive up to 1 year, the statistics for long-term survival is much better after that. 75% of patients who die within the first year of transplant have to do with infections, be it viral with CMV or non-CMV infections in general, okay? I mentioned this as the first slide because patients who are in need of ECMO and transplantation are the ones that are right here, having a 15% less survival potentially. So at UCSD, we've changed the dynamic to a point where we're matching up the survival of this candidate to the candidate with the low risk group there. In our experience, as you can see in this graph right here, this deep blue is CASD, represented the code for UC San Diego's lung transplant program. Compared to the US, these are non-hospitalized patients, hospitalized and ICU. As you can see, the people who we transplant in a hospital state or ICU level is by far greater than anywhere in the nation. And these hospitalized patients, these are high flow nasal cannulas, not just 2 liters in the hospital, okay? So part of this, again, we had examples of COVID ARDS, but by the time they come to us, we're at 6 weeks, there's no recovery. They've gone into potentially fibrotic phases. So, kind of caveat, 48-year-old contracted COVID-19, developed the ARDS. As you can see, this dark area here, this is all air around the lung. The lungs are all fibrotic. He's got the tracheostomy right there. Has had multiple medical issues, right? On mechanical ventilation, on ECMO, lung collapses, multiple chest tubes, and not only the fact that he's got the chest tubes, but he also has had empyema, which is infection in that pleural space, so that's somewhat of a concern when we go in and we want to give immunosuppression and the field could be infected. Given the fact that they need some pressors, he developed gangrene and had to have an amputation. Code blue during the oxygen exchange, ended up having a left hemothorax with 1 chest tube placement, had to have embolizations. So a lot of these things have led to, could he get into a transplantation? So I'm not going to talk about the ventilator itself because of all the complex aspects of what he dealt with, but I do want to talk about what flow he needed on ECMO, 6.21, and the sweep. So really, the lung is not working, right? We're doing everything for him on the mechanical ventilation and on ECMO. Despite that, you can see pretty hypercapnic, right? So He ends up getting his transplant. So this is a pre-transplant X-ray after the chest tubes and all that were able to be removed. And this is a little bit like 10 days after his transplantation. You can see the stark difference between the scars in the lungs here versus there, right? The case was performed on ECMO and was decannulated off ECMO, right? This is him off ECMO. This is what the airway anastomosis should look like. And then the anastomosis is basically the connection between the two. And I show this as 262 days on ECMO. Okay? So that's, again, I'm painting a picture of what's not possible only, but what we've tried to make it as probable. And as physicians, as nurses, as respiratory therapists, we're all integral in this multidisciplinary process. But again, there's certain tools that I need to use, and I have to be at the bedside quite a bit, right? So when we're looking at how he was at the height of issues with chest tubes and so forth, and he's walking out of the hospital, right? He's walking out of the hospital about 15, 20 days after transplant. And he's 3.5 years without any reversible, which is the acute, or irreversible rejections. That's pretty good. So how often is this successful, right? Germany and Hamburg from 2012 and 17, what they looked at was what is the possibility of people who have undergone transplantation with ECMO, right? So we have 38.6% bridge to transplantation compared to those that are non-bridged. The recipients were 18 to 65 years of age. Mean age was about 49, 96% of ECMOs. The median time from bridge to transplantation on ECMO was 29 days, with the highest one with 129, much shorter than what we're dealing with, right? But among those, how many of them ended up getting transplantation? Not all of them, right? But those who did. So when we're looking at bridge to transplantation versus not, the 1-year survival was 79%. At 3 years was 63%, right? So that first graph that I showed you, 1-year survival in nationwide should be expected at 90%. So they're already lower, right? The non-bridge, almost there at 86%. Okay, so this is Hamburg. But what about in the United States? In Colombia, they had a 2009 to 2018 looking at their ECMO patients. So 70 out of 121, so 59% were successfully bridged to transplantation. So 50 patients, even though they were selected, did not get to that point, right? And from a time standpoint, if you're looking at it like 12 days, not really that much. So why is it they're having a high unsuccessful rate, right? So these are the things of how we looked at it. And again, bridge to transplantation, nearly what should be expected, right? So we ended up publishing our publications in the ARDS from COVID-19 of 9 cases. And as you can see here, sorry it's not as big as I would like it to be. The median length of stay on this one turned out to be 57 versus 25, right? But of those patients, overall, the 1-year survival was superior than prior publications. We're at 100%. So again, what is it that we're doing that makes it much more successful, right? And part of this is just a partnership, communicating and understanding what we're all doing, knowing that some of the tools that are available to us isn't possible. So first things first, ICU level of care, there's basic principles, there are some level of evidence. When it comes to our field, we tend to do some things that are counterintuitive, meaning we try to limit steroids, right? So if you have someone who's on prednisone for more than 15 milligrams, long period of time, they end up getting issues of wound dehiscence. And I'll show you a picture of what that really means, okay? Myopathy is a big issue. So pre-transplantation phase, it's a continuum of care for us because the exit strategy is either death, which we're trying to avoid, or to get a successful long-term transplantation. Destination is not just transplant and they only survive a few days, right? That's not the goal. Specialized training with RT and PTs, right? So this culture of movement at UCSD that I'll show you wasn't always the case. So when I joined in 2015, when I came, there were people who were suppressed with sedation. Don't move. Immobility was the way to go. Like, lighten up the sedation. Let's get them moving. Why not? It can't happen. It's not possible. We started using portable ventilators. We went moving, right? So then it became possible. The very first 3 ambulatory ECMO at UCSD were all patients. Part of this was my partnership with the physical therapist at USC, which was top ranked in the nation at the time. We found ways to work together. Now you come to UCSD and just like over here in Sharp, people are ambulating, right? This has become the norm. But then it becomes a matter of how much, right? How much can you walk? And we'll go through that. But more importantly is also a matter of continuum of care. The lungs are not going to get better, right? So when we put new lungs in, it's not that the lung isn't going to work. We now need to think about all these other areas. So it's not just barotrauma like he developed, but ventilatory-induced diaphragmatic dysfunction can also happen. So the question was, what is the bare minimum amount of mechanical ventilation with regards to spontaneous breathing trials we can use to get the diaphragm moving a little bit more? Okay, so this publication in 2019 is a continuum of other publications that show, there's a previous one in New England Journal of Medicine, 30 minutes a day is sufficient for successful weaning and extubating of patients. So 30 minutes a day, can we do that while they're on ECMO? And what we learned was, if we didn't do this, like the first case that we did for a bridge to transplantation with the COVID patients, it took us about 6 weeks to get them off the ventilator post-transplantation. So we moved that up on the pre-phase. Like this patient here, 15 days. Another one was 12 days after transplantation. They're off the ventilator, walking around, doing well. So this is really key in terms of partnership with RT and physical therapy and nursing. Age is a major determinant of what you can overcome in terms of robustness. There are some things that we're looking at in terms of how do you quantify grit. That I can't speak about enough. Generally, patients who are much older, 60s, 70s, we get back of, this is hard. I've lived a good life. I don't want to do this anymore, right? Younger folks, there are some people who are like, I can't handle this, but those who have grit, irrespective of age, they're able to push the boundaries. The minimal obstacles are just that, just a little setback. Whereas if you don't have that mindset, that minimal obstacle is a mountain to climb and done with, right? And we also have to be mindful that there was a donor family who gifted the donor's lungs, the generosity, then we're dealing with that as well. And last, one of the other reasons why ECMO is not our friend is hemolysis that can happen, right? And we give blood transfusions, and we're supporting the patient, but at a potential cost of developing what's called panel-reactive antibodies, and we'll go through that. And this may be prohibitive for transplantation. So functional status, I think you guys have already gone through this quite extensively today, but just kind of the thread for our talk as well is I go for the simple stuff. What is it that everyone has capabilities for? So again, this is going to be broader than just the ECMO aspect. Some people will say, I don't have enough money to drive to pulmonary rehab, which is 2 hours away. I don't have someone who's taking me. But everybody has pretty much a chair at home, right? And what we've developed was looking at assessments from all the transplant programs. Looking at quadricep muscles is really key. So sit in the chair, stand up. Sit in the chair, stand up, right? So there's this whole sit to stands or squats that we talk about. In physical therapy realm, you demonstrate good strength if you could do 5 sit to stands in 30 seconds. But I'm writing here 15 sit to stands in 1 minute because I am trying to overcome the degree of steroids. Right? And the steroids we're giving is 500 milligrams of solumetrol up to 1,000 milligrams. So they can develop myopathy real quick. So we do that 1 time, 2 times, up to 3 times a day, bare minimum. And then we tell them, well, you can also purchase this, just like what we have in the hospital, financially $40 on Amazon. So they have it at home, they have it in the hospital, and we say you do 10 to 15 minutes 3 times a day, bare minimum. Obviously, to some people, when they're on high flow, they're going to be limited to how much they're going to walk. That's more endurance training, whereas we're thinking about strength training with this. Okay? When it comes to, do you want to do it partially? Do you want to do it every day? This is what the graph pretty much describes to us, which is if you're looking at the pre-transplant in terms of daily steps, post-transplant 1 year compared to healthy, we do expect them to get improvement, but not to the comparators of healthy because of the degree of recovery, the myopathy from the steroids, and so forth, right? But this part here is rather telling, which is this training has to do with daily exercises compared to controls, with control was do it periodically. And I'm going to say to myself, I'm going to exercise twice a week. It becomes twice a month, right? So that's what you're seeing, is daily therapy is successful in the short-term and long-term basis there. So again, when we're looking at it, it's just a continuum. This patient right here, as you can see, this was one of the earlier gentlemen who had primary ciliary dyskinesia, ended up getting on ECMO early after transplantation because he developed rejection and primary graft dysfunction, and we'll go through that. And this lady right here, she's young, she's pretty much within 3 hours of post-extubation for pulmonary hypertension. You can see how thin she is. With the pulmonary hypertension, she has a catabolic state from all the heart failure issues. She had developed ascites that we had to do paracentesis, and when you do that, you take protein away and malnutrition can happen. She is 8 years out, doing well. Her 2 daughters were 3 and 5 at that time, much older now, right? So this is one of the aspects where I feel blessed doing what I do. I make a difference, not only in terms of making things, like we said, probable, but really making an effect of long-term survival for patients who we didn't think would be happening. So again, just for us to know what the anastomosis is, this is the connection between the donor airway and the recipient airway, and what it's done is an end-to-end anastomosis, as opposed to telescope, meaning putting one of the airways into the other one. It used to be that we used a telescoping method, but you cause more strictures in that situation. But the end-to-end is a lot better. This is what the airways should look like. These blue lines here are the anastomoses, or the sutures at the anastomoses. This right here, you can see that there's less blood flow to that area, mainly because we've taken away the bronchial artery and they only have the pulmonary artery there, okay? All right, so the dehiscence we were talking about is, again, you see the sutures. It should be like this. This area right here, or it should be right here. This area right here is basically an opening, which is representing there, and it's tracking air into the pleural space, okay? Generally speaking, to try to go in there and do a reoperation, it's even harder. So some of these patients, we end up having to put stents. And on top of it, then, other issues that kind of come with it. So this is, again, primary reason for strength and also limiting wound dehiscence at the level of the anastomosis, but also at the surgical incision sites there. Overall trends in terms of the age group, as you can see, there are more people who are getting transplanted at an older age, but you can have a number of age-related comorbidities, as you can see here: strokes, sleep disorders, the coronary artery disease, osteoporosis, malignancies, but also intolerability to some of these medications. So we use 3 drug immunosuppression. One is prednisone. One is tacrolimus or cyclosporin equivalent, which causes a lot of neurological disorders, tremors, right? And so if you have the myopathy and these tremors, fall risks. There's a third one, which is mycophenolate or equivalent azathioprine, which causes myelosuppression, low white blood cell counts, low red blood cell counts. Again, if we have to take them off these medications, then the risk of rejections tend to go up as well. So for the ECMO patients, our age criteria typically has been around 65 at the oldest. We don't do transplantation with ECMO bridge higher than that. The other reason, so this is an article that showed COPD patients, emphysema with alpha-1s, and I put it in here. I know it's not ECMO, but just to see, again, the age criteria of what people are able to tolerate. If you can see less than 60 years, they've gone through multiple complications, right? Whereas this greater than 60, not as many of them with regards to causes of death there, okay? All right, the panel reactive antibody that we talked about, the blood transfusions. Basically, when you have a recipient who's waiting for transplantation, you're looking at blood types. You want to match that up. You want to match up the immunological profiles as well. So the panel basically means out of 100 people who, within the community, does my immunological status, do I have antibodies to those antigens, those markers? And if I do, then it'll be a positive panel reactive antibody. The more the positive, it means that there's more donors out there that I will react to, and then if I just get transplanted with them, I will reject right away. So the cutoffs are 20% and 80% here on the publication through the International Society for Heart and Lung Transplantation. As you can see, when they're positive, majority of them are more than 20%, meaning 50s, 60s are included, right? Very few are over 80%, right? A different way to say this. These ones that are over 80%, most likely, let's put in as 85%. 85% of the time, I will find a donor that I will react with, okay? So why do I talk about this again with the ECMO? When I did the blood transfusions, if we get to higher values, we will not find a donor, most likely, right? That's really the big basis of this. There is a difference in terms of survival, right? So you have patients who have panel reactive antibodies less than 25% versus more than 25%. Stark difference there. There's been arguments, well, you can give treatments, draw those immunosuppressions down, and you can do that through plasmapheresis, taking the plasma out. You can give them IVIG. You can give them different immunosuppressant therapies, and it can work. The problem is they get into sepsis. And if you're septic, we can't transplant you, right? And so this is a publication out of Duke, and they said, well, we've done this, and 9 out of the 18 ended up transplanting, but all of them had a negative cross-match, meaning they didn't even have to do that. So these are, again, the reasons why we want the patients to be as robust as possible. Do the spontaneous speed training earlier, because time is not on their side, okay? All right, so if we go through the indications and contraindications, COVID is one, right, with the pulmonary fibrosis. So it kind of fits into the interstitial lung category. But then there are other reasons why people would need a transplantation. It may be obstructive disease like emphysema, be it genetic alpha-1 antitrypsin deficiency or non. It could be cystic fibrosis or bronchitis or pulmonary hypertension. For these two, we have to do strict bilateral lung transplantation. The reason is because when you have bronchiectasis like this, you'll have a lot of mucus purulent. You don't want to transfer all that native lung infection into the new allograft. For the pulmonary hypertension, it's the vasculature. If you only do a single lung, which has a low resistance, and you leave the one with a higher resistance, all the cardiac output preference will go to the low side, which is the new lung, and will overload the lung, get pulmonary edema there. Am I going at an okay pace? Or do you want me to slow down? Okay. So these are the guidelines for referral, guidelines for transplantation. This is something that I actually disagree with. The guidelines for transplantation should be up here for the guideline of referral. The reason being, a Bodie index of 5 is really not that severe. This was a category basically to see what is the mortality at 5 years. The referral is generally 7 or greater, okay? But if you look again at patients who guideline for transplantation with an index of Bodie of 7, okay. But look at this one, hospitalization, exacerbation with a PCO2 greater than 50, has pulmonary hypertension, FEV1 less than 20. These guys need to be seeing us much earlier, right? And when we're coming out in the community, this is what we're talking about. We'll do our best to make things happen. But on times, we get phone calls and saying, I'm about to intubate somebody. Would you consider them for transplant? I don't know what their insurance will cover. I don't know about relocation. I don't know about caregivers. Did we do cancer screening? No, we didn't do that. There's a bunch of things that take several weeks usually that we're able to get done within a matter of a few days, but they have to have the buy-in, right? They have to go through the education to know taking medications. So after I graduated from fellowship, I went up to Stanford to get some extra training. And there was this one young lady, she's 42 years old, and had 2 young kids, kind of like that case that I showed you. 4 or 5 years old, she's intubated, doesn't recover. The husband has to make this decision. Do we save her life, right? So she gets the transplant. So she wakes up, she's being told, you got new lungs, here's the medications. Unfortunately, the medications kept causing her to have intractable nausea and vomiting, that she required IV antiemetics on a weekly basis. So every other week she's in the hospital, right? Quality of life is poor. Basically, like 3 months afterwards, she passed away, right? So these are the challenges that if you don't have the buy-in, and the husband made I think we would all make the same exact decision for our loved one, right? Especially a young mother. But those are the challenges that we do have to go through, and each person has to buy into it. Cystic fibrosis, again, if you're looking at it from an exacerbation, look at the difference between here, right? The referral is requiring ICU stay, that's referral. This is right. This needs to be flipped up. Same thing for these guys, need to be flipped up. Different way. I'm more of a visual person, so that's why I try to include all this in here, right? So the one on the right, on the left for you guys, is basically for patients who have pulmonary fibrosis. And pulmonary fibrosis, a lot of times my colleagues will say, hey, this patient's doing well and is really, lung function slowly coming down, not a big deal. And then they'll talk to me about another one who's like really, the lung function is really bad. So this is what we're talking about here, the distinction between this guy with a rapid progression versus a stable one. And this is based on changes in the forced vital capacity on the spirometry. So anything more than 10% is a poor prognostic sign. This one doesn't do the good justice, but there is a little bit more of a rapid or medium prognosis. And they talk about 5 to 10% change. But if you look at the overall mortality between that 5 to 10% change and the greater than 10% change, they're nearly the same. So then we're like, should have been referred earlier. The other thing is that this lightning bolt, this guy wasn't a Chargers fan, but the lightning bolt was along the lines of an exacerbation. The exacerbation tends to be, in the absence of infection, getting worse. And you have about a 50% mortality in those situations, despite being on high flow O2, getting on high oxygen. But again, look at the stable one and the slow progression one. So there's a push to say, if you have IPF, talk with the transplant doctors earlier. See what happens in the worst case scenario, COPD. COPD, I think this is a hallmark of a lot of hospitals trying to reduce readmissions, right? This was a really eye-opening thing for me because it kind of substantiated some of the things we were seeing. There was an article out of New England Journal of Medicine that said, if you're looking at what are the predictors of future exacerbations, it tended to be history of exacerbations. Didn't have to do with FEV1, PO2, PCO2, none of that mattered. Had to do with exacerbation. This year in 2012, we talked about sentinel exacerbation. As time goes on, the exacerbations become more frequent and more severe. So again, I'm asking the questions, when was your last exacerbation? How long were you in the hospital? What did you get? When's the next time? All that. These are all, as a respiratory therapist, you will also potentially see that in the hospital or maybe even in the clinic setting. With pulmonary hypertension, it's a little bit different in terms of your cardiac output. You're dependent on echocardiogram, right heart catheterizations, and so forth. But again, you can kind of see that the cardiac output's starting to come down a little bit, right? When the New York Heart Class 3. These are the groups that we probably do need to see. But we end up seeing them here on the decompensated side. So again, a lot of aspects of how I look at things is not like how we're sitting around, right, in an immobile state. It has to do with the functional indicators. And so in clinic, I'm not asking them what their O2 is at rest. Doesn't matter. It's what are they doing functionally, right? So we can have a patient with IPF 2 liters at rest, but then when they're walking, it's 15 liters. So when in their hospital, this is what I'm checking for. I look at heart rate variability. How many have heard of heart rate variability? Very few, right? So heart rate variability means you're sitting here, I ask you to stand up and do the sit to stands, right? Your heart rate should go up. When you rest, it should go down pretty quickly, right? But these patients, heart rate will stay up for a longer period of time, right? So I bring this up because sometimes there's this discussions with our own respiratory therapists. Why did Dr. Afshar's got his own, he doesn't believe in anything. He just does what he wants to do, right? Puts him on high flow, this and that. But what I'm doing is I'm doing these assessments on a daily basis. Sit, stand, sit, stand, sit, stand. And I'm noticing heart rate, which was 60 at rest, is now at 140 with exertion. And I'm waiting. And it's staying 140. And it goes down to 138. And it goes down to 137. 5 minutes later, still 120. So if I am supposed to make sure that the patient's going to be successful for a good transplantation, he has to exercise, right? Knowing this cardiopulmonary limitations. So when I'm doing this assessment, one, can we push through with what we're doing? Or do we need to escalate? Do we then go into intubation? Do I have to say, hey, let's call up Dr. Goltz, let's do ECMO, knowing the harmful effects that can potentially happen? So these are all the things that we look at functionally. Now, if I use the example of the case, when he is on ECMO and walking around, I'm not using, put him on trach collar. That only makes me feel better. It doesn't do anything good for him, right? He's get put on full control while he's on mechanical ventilation. The sweep goes up on the ECMO. I want to take everything away when it comes to causing hypoxemia or increased work of breathing, because the goal is exercise, exercise, exercise in that situation. Then when he's resting, I can then do the respiratory exercise at a different time with the spontaneous breathing trial. I will say it again. Exercise, exercise, exercise. All right, so again, I've touched upon it. We try to avoid sedation as much as possible, try to avoid paralytics. The one cases that we're getting a lot more of were called MDA5. These are rheumatological conditions, kind of like with the dermatomyositis, really high catabolic state, inflammatory cascades, high doses of steroids, paralytics. We're having a hard time with them, but everybody else, we pretty much are able to follow this in terms of the protocols. We've changed from absolute and relative contraindications mindset to modifiable and non-modifiable. If you have shock, we can still transplant you as long as it's not septic. So again, going back to hand washing, making sure the lines are good, all those basic principles, we want to avoid sepsis. There are some infections that are highly virulent. If we have the ability to push through with antimicrobial therapy, we will. And sometimes we've used bacteriophage therapy. Have you heard of bacteriophages? Maybe no? It's basically utilizing viruses to bring down the minimal inhibitory complex so then the bacteria is eradicated with antimicrobial therapies. Historically, this group right here, HIV, it would be hepatitis B and hepatitis C as the absolute contraindications. This is no longer the case. We just transplanted someone this year with HIV, not AIDS, right? So it means CD4 count has to be above 500, no opportunistic infections, able to get antiretroviral therapy. Then now, because of the fentanyl overdoses and deaths, we're having a lot of folks who have hepatitis C, right? And we've been transplanting people who've never had hepatitis C with donors that are positive for hepatitis C. Give them 1 week of treatment, eradicate the virus. They're young donors, 18, 20, 30 years old, robust outcomes, no effect on rejections for these patients. But there are some things that are still troublesome. So Mycobacterium abscessus, if you have not heard of this, this is a non-tuberculous mycobacterium, rapidly growing. It can affect the sternal wound infections. It can cause disseminated infections if it's not controllable. Over the last 5 years, we have transplanted 3 patients doing well, but they have to have control. We have to have the time. Active TB, Burkholderia cepacia GMR3 specifically, are not able to. And this fungus here, these are multi-drug resistant type of organisms. Again, critically unstable patients will be able to, unless they do not have rehab potentials. All right. Here, this is a gentleman who had tuberculosis, autopneumectomy. This chest wall issues is so chronic, we're not able to fix this, right? This basically is an emphysema patient. This is another one. I don't know if you've heard of this here before, which is a saber sheath trachea. It can be even more severe than this. The cartilage gets really thick and hardened. You intubate them, you can rupture the airways. So again, the new lungs go in there, but we're having these airway issues that are prohibitive for transplantation. Body mass index. Not fat shaming anybody. Okay, not talking about, anorexia aspect. The BMI aspect are surrogates. So as you can see here, the BMI that's greater, it's a higher surgical mortality. The previous discussion we talked about compliance of the lungs. How do you assess it? Can you increase your PEEP and this and that? When you take away the nerves, when you add in a smaller chest wall cavity and the lung naturally wants to come down, and then you have the abdominal adipose tissues pushing up, you get a lot more atelectatic issues, which thereby leads to more infectious complications and so forth. The BMI less than 17 has to do with wound healing, the dehiscence that we talked about, just like with the steroids, but also clearing out infections. I had a young lady who had a pleural infection that lasted about 8 weeks. After transplantation, her BMI was like 15. As soon as her BMI hit around 18, infections went away. Cancers, all that. All right, so what do the surgeries look like? If we can do a single lung transplantation, it's a thoracotomy like this here. This is a lateral sternotomy, which is also known as clamshell incision. There are times where you can do a median sternotomy, like a cabbage, in certain situations. These are the types of incisions we're talking about. They're not small, right? We're going through the skin, muscles, bones, all that. And then we kept asked by the referring physicians, where's the patient on the list? Did you get an offer? Yeah, we got an offer. Is the offer good? Not every first offer is going to be that great, right? So we'll have someone who, this donor lung, it looks pretty good, but they're too big for our patients. So it got turned down here. This chest CT scan looks like it's got a little bit of aspiration, which, as most patients do with either subarachnoid hemorrhage, strokes, gunshot wounds, they're going to aspirate. So we looked at this. The gas exchange looked great. We accepted the lungs, which tentatively is a two-phase acceptance. First one is imaging labs. The second one is going into the donor hospital, taking a look, right? So this CT scan, everything looks great. This is what it looked like. It's now infarcted, right? So the PE develops, we turn those lungs down. All right, international data, as you can see, there's more and more transplants happening worldwide. The transplants predominantly are bilateral lung transplantations. The reason is long-term survival is better for them. The native lung complications can be about 60%. So if you have an emphysema patient, pneumothorax, lung cancers, all those that you may be able to avert. However, if you do not have someone who's robust, they're not going to be able to tolerate two lungs. So single lung may be the only option for them to live. When we're looking at the different disease states, you can see cystic fibrosis is the best. Idiopathic pulmonary fibrosis is the worst. The earliest phase is a rapid drop-off here. This has to do with primary graft dysfunction. This is lung transplant's equivalent of ARDS. Mainly when the lung engraftment is placed, you unclamp, all those immune cells rush to the lungs. You get a lot of cytokine releases. And so you should see a chest X-ray be like this, nice and with regards to the timing, compared to really severe lung damage, which is grade 3. Okay? The treatments generally are increasing FiO2, lower tidal volumes, aggressive pulmonary toilets, nitric oxide, diuretics, and if need, ECMO support. There are some predictors. The predictors are if the pulmonary pressures are higher, you'll develop it. If you're looking at the grading of here, the mortality is much more with the higher grade primary graft dysfunctions. And then from a donor standpoint, right, even the donor age as it grows higher, it can be a problem. Look over here, ECMO bridged lung transplantation is a factor for that, right? So all these things that we're doing, that you're part of, has implications on success or not, right? Just as an idea of post-transplantation, cardiopulmonary bypass, almost equivalent to ECMO, but when you're looking at the chest x-rays on day one, you can kind of see some opacities there. Looks like it's getting a little worse, right? Compared to off pump, the lungs are actually not that bad. So again, we have to take into consideration all those steps that come into transplant purposes. Again, you can see the differences in survival, bilateral versus single, bilateral, single. Conditional survival is basically if you survive at 1 year, it goes from 7.6 to 10 years, 4.7 to 6.5 years. There is no difference among genders. There's no difference between a woman getting male lungs versus a male getting a woman lungs or equivalent. They're all the same from that standpoint. In terms of long-term survival and what's the cause of death, as you can see at the beginning is infection is the cause of death. Over time, long-term is the irreversible rejections, graft failures, infections, and so forth. It's challenging. It takes a lot of partnership among everybody on the recipient side, on the donor side, on the referring side, and partnership with all of you. So thank you for what you do, and hopefully this 90 minutes went by like it was 30.